Okay, so let's talk about gastrointestinal ligaments. Okay. So here we have falciform ligament, hepatoduodenal ligament, but the way I'm going to tell you, it's going to make your life super easy. So just remember a couple of things. So you have the ventral mesentery. That is going to give you two things. One thing is the falciform ligament. The second thing is your lesser omentum. Give me 1 second. Lesser omentum. That lesser omentum has two ligaments, hepatoduodenal ligament and hepatogastric ligament. So what is ventral? I said ventral always means anterior. So these are anterior mesentery. This is the mesentery in which that these things are putting the organs, attaching them to the anterior wall. Ventral mesentery attaching the organs to the anterior abdominal wall, in which you have the falciform ligament, in which you have a lesser omentum, which has two ligaments in there, hepatoduodenal and hepatogastric ligament. Okay. Now, since we talk about ventral mesentery, let's also talk about dorsal mesentery. Dorsal means posterior. That means it's going to attach the organs to the posterior abdominal wall, or the posteriorly. It's going to attach the abdominal contents or abdominal organs posteriorly. That's the dorsal posterior mesentery. It has splenorenal ligament, and also it has the greater omentum. That greater omentum has two ligaments. One is the gastrocolic ligament, and the second thing is the gastrosplenic ligament. Now coming back to what I just talked about, just look here: falciform ligament, hepatoduodenal, hepatogastric ligament, hepatoduodenal. So what is falciform ligament? It attaches liver to the abdominal wall, anterior abdominal wall. It contains the ligamentum teres hepatis, patent paramumbilical veins. It is derived from the ventral mesentery. It derives from the ventral mesentery. Great, that's easy to remember. What about the hepatoduodenal? Just look at the names: hepato, liver, duodenum. So it's going to go from liver to duodenum, right? And this is important as it has this portal triad. Portal triad is what does it consist of? It consists of proper hepatic artery, portal vein, common bile duct. It is again derivative of the ventral mesentery. You already know that. But let's talk about this thing, clinically important: Pringle maneuver. This ligament, if you were to compress it manually within like thumb and the index finger, or with a vascular clamp in the omental foramen, you have, where's the metaphor, to control the bleeding. So you could just push on it to control the bleeding from the portal triad, to control bleeding from hepatic inflow. Portal triad is inflow, which is portal vein, hepatic artery, versus the outflow. So if you can block the bleeding just by doing the Pringle maneuver, then you can right away tell that it is coming from the portal triad, which is the inflow. Now you will say, what is inflow, what is outflow? But let's just explain. Portal triad, let's say, it's putting in everything from hepatic artery and the vein. All that circulation, all that blood is going into the liver. That liver, some artery is going to come out, and the vein, the vein is going to come out, which is going to go to IVC, right? So that vein that comes out of it is the hepatic vein that will go into IVC. That's the outflow. So if you can do Pringle maneuver and stop a bleeding here, you can right away tell it's coming from inflow, basically portal triad. But even if you do, now the next thing is you have blocked this thing, the inflow, but still you keep bleeding, then you got to think about either you have a problem in hepatic vein or you have a problem in IVC. Okay, so that's what we have there. Let's read here. They will mention that it worsens the outflow of hepatic vein and IVC, borders the omental foramen. They are saying hepatoduodenal borders the omental foramen, which I'll show you later, which connects the greater and lesser sac. It is a part of a lesser omentum. We already know it's part of a lesser omentum. Great. Let's go with the hepatogastric. Hepato, liver, gastric. Now you have the stomach. But what sort of gastric? Lesser curvature, right here. Lesser curvature. That's the hepatogastric. That hepatogastric ligament, where's the hepatogastric? Over here. It contains the gastric vessels. It is a derivative of the ventral mesentery, separates gastric and then separates greater and lesser sacs on the right. May be cut during surgery to assess the lesser sac. Okay, yeah, you can cut it to assess the lesser sac. So the question is, for example, if you want to do what is called the banding, the gastric banding, right? Adjustable gastric band in obese patient. So in those obese patient, you want to put the band on the cardia of the stomach and constrict that area. So how can you reach? I'm showing you a picture here. How can you reach the cardia? Let's say the cardia is here, right? How can you reach the cardia? How can you fully constrict that band to go through it? So easy question. Well, you have to cut down the hepatogastric ligament in order to go through the whole, like circle the whole thing. So that's what they're basically saying. May be cut. Wait, let me go back there. Okay, here. So they're saying may be cut during surgery to assess the lesser sac. So what sort of surgeries? Adjustable gastric band procedures in obese patients. That's one of the things. But yeah, that's pretty much it for the ventral mesentery. Let's talk about the dorsal mesentery now. The dorsal mesentery, in which we have the first thing, you have the splenorenal ligament. Spleen is spleen, renal means renal. You're connecting spleen with the renal ligament. So you're going to have splenic artery and the vein and the tail of pancreas. Remember, the tail of pancreas was intraperitoneal. So that's what here it is, intraperitoneal. Tail of the pancreas. And you have it is a derivative of dorsal mesentery. That dorsal mesentery gave off splenorenal and the greater omentum. Omentum gave us gastrocolic, gastrosplenic. Gastrocolic means from the greater curvature of the stomach to the transverse colon. And let me show you actually this thing. So here's the greater curvature. From the greater curvature to the colon, you have this gastrocolic ligament. And here's the spleen from the look at this one. This is the gastrosplenic now. From the stomach to the spleen, gastrosplenic. So let's read that. In gastrosplenic ligament, from the greater curvature to the spleen, what do you have? You have a short gastric left and gastroepiploic arteries. It is a derivative of the dorsal mesentery, separates greater and lesser sac on the left part of the greater omentum. So yeah, look, I mean, basically you're going to take a look at a picture and kind of understand, and it's super easy if you were to name them here. Let's just look at it. This is the falciform. This is connecting liver to the lesser curvature of the stomach. So you have the hepatogastric. From hepatogastric, you have the hepatoduodenal, you have the gastrocolic, gastrosplenic. Just by looking at it, you can tell. But the important thing is, what does it contain? So this one contains the hepatogastric contains the gastric vessels, while the hepatoduodenal contains the portal triad. That is important, and the Pringle maneuver and the gastric bands. Okay. Coming to the next thing, what do we have here? We have digestive tract anatomy, MS. You have the mucosa, submucosa, muscularis, externine serosa. Important thing is you have the MS for Mesenteries, S for MEISS, mesenteries, S for secretion, and then you have the other M. M is for mesenteric, right? Mesenteric, M. Mesenteric, M for motility, M. So that's how you're going to know that. Okay, yeah, one more thing that. So in this MSMS, that's the mnemonic basically. S for mesenteries, SS. SS, mesenteries, secretion. Great. Now MSMS, we talked about S, which S is mesenteries and secretion. M, that is mesenteric. M for M, mesenteric. Now you have the inner circular, outer longitudinal. In between this, you have this mesenteric plexus, which is motility. We just the motility. M, 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 S, S, S. Okay. Other than that, yeah, that's pretty much all we have here in this thing. Now we are going to talk about gastric tract histology. Digestive tract histology. Here, the esophagus. Important thing is the non-keratinizing stratovascular epithelium. Upper 1/3 is striated. Middle and lower 2/3 are smooth muscle. Striated means you have a voluntary control of the upper 1/3, and smooth means you don't have any. This is involuntary. You have no voluntary control over it. That's basically swallowing. So you have a voluntary control on the top, but not at the bottom. Coming to the stomach. Now here what we are going to talk about is what is prominent in these structures. Like what is the prominent cells in all of these structures, so that whenever somebody mentions it, we would know, okay, they're talking about stomach, either talking about duodenum, jejunum, or what. So in the stomach, you have basically you have the parietal cells, which are pink, parietal cells, which are pink, eosinophilic, and the chief cells, which are blue. So how do we know it's the stomach? If we see pink cells, and in physiology, it's going to mention where they're located, at the upper part and the lower part. So that's also important. But here is just the parietal cells and the chief cells. Duodenum, second thing, that you have to think about in duodenum, you're going to think about Brunner's glands, which are the bicarb secreting. If you think about villi and microvilli, you will see that villi everywhere. But important point of duodenum is, which they can test you on, is this Brunner glands, which is the bicarb, Brunner bicarb, BB, right? Secreting cells of the submucosa, okay? And sometimes they can also mention as a branch submucosa. See, they have mentioned submucosa. We can say branch tubular submucosal cells. So branch tubular submucosal cells are Brunner glands, which do what? Secrete bicarb. Why do we need bicarb? Because the acid is coming from all the stomach. We want to neutralize it, so that's why we need the bicarb from the duodenum. Other than that, you have also one thing is what secretes the most bicarb in the stomach. Not in the stomach, but in the digestive tract. So you have this thing. One thing is the Brunner gland. They secrete the most bicarb. That's the most. They secrete the most bicarb. Second thing is the pancreatic ducts. They also secrete the bicarb. The first thing is the Brunner gland. The second thing is the pancreatic ducts. All right, coming to jejunum. Jejunum, this is all you're going to look at, is the plica circularis. Plica circularis, they're taller, more prominent, numerous, versus ileum, which leads to feathered appearance with oral contrast and increased surface area. So these plica circularis, they are going to give you this thing, feathery appearance with the oral contrast. So you have a feathery appearance of the jejunum, like this. Feathery appearance of the jejunum, that is going to give you, due to plica circularis, you will not see it anywhere because you have them here, which are taller, more prominent, more numerous only in the jejunum. Okay. Now think about ileum. Ileum, you're looking at the Peyer's patches. Peyer's patches, which are the lymphoid aggregates in the lamina propria, submucosa, plica circularis. Again, they're more proximally in the ileum, but again, they are more prominent in the jejunum. That's their characteristic. For ileum, the characteristic is the Peyer's patches. And also you have this goblet cell, but again, the goblet cell is going to be more common in the colon too. So in the small intestine, we also see the goblet cell more in the ileum, but in the colon, we also see the goblet cells, but that's colon, not small intestine. In here, in the colon, we just have the novilli structure, goblet cell, the novilli structure. Again, if you look at the crypts of liver cone, you already have the crypts of liver cone. So just think about goblet cell novilli. Whenever you see novilli, that's the colon. Okay, yeah, that's what we have here. Let's move on with the next thing. Aorta and branches. Wait, let me just look at one thing. Okay. Okay. Abdominal aorta and its branches. So, as we already talked about, the abdominal aorta does give a couple of branches, but here we're specifically going to talk about its branch, which is the SMA, and the branch, which is the IMA. Okay, so arteries that supply the GI structures are single and branch anteriorly. And what are the GI structures supplied? So you have the celiac, the SMA, the IMA. All of them are anterior and single. But arteries that supply the non-GI structures, they are paired and branch laterally and posteriorly. Very important here that there are two areas of the colon that have a dual blood supply from distal arterial branches, which are the watershed areas. They are susceptible in colonic ischemia. One thing is this area, which is the superior, this is the splenic flexure, which is the border area between the SMA and IMA. And the second thing is this rectosigmoid junction, which is the IMA branches, the last sigmoid arterial branch, and superior rectal. Oh, where did I go? Okay, yeah, superior rectal artery. Okay, that's the watershed area. So if you have hypotension, if you have basically shock that causes hypotension, the most likely the area that you're gonna mess up causing ischemia, non-obstructive, again, non-occlusive ischemia or non-occlusive ischemic colitis. That is going to be two areas. One thing is the splenic flexure. Second thing is the rectosigmoid junction. Let's talk about the nutcracker syndrome now. Nutcracker syndrome is the compression of the left renal vein between the SMA and the aorta. So normally you have a 45-degree angle, which is here, but in any associated features which are here, like all of these, but I'm going to mention later, you have reduced the angle to 20 degrees. So as soon as you did that, you're constricting the left renal vein. The problem now is, let's read that here from the book. So you have the compression of the left renal vein between SMA and aorta may cause abdominal flank pain, cross hematuria. You're like, wow, how did that happen? And also you have this left-sided varicocele hematuria because you are you have constricted the renal vein, so no blood is going back, so it's just remaining in the kidneys and causing hematuria. Also, you have the left-sided varicocele because of you have this left gonadal vein that was draining into the left renal, and that left renal was going into the IVC, back into the IVC. So this, because you have obstructed this place here, so no flow is going to go back from here. So you have hematuria. No flow is going to go up. So you're going to have a varicocele, and you will have abdominal pain as well. That is the nutcracker syndrome. Now, superior mesenteric artery syndrome, SMA syndrome. It is characterized by intermittent intestinal obstruction symptoms, primarily postprandial pain when SMA and aorta compresses. So you have the aorta and you have the SMA. There compresses the duodenum. Okay, they're compressing the duodenum. Which part? The transverse portion, the third part of duodenum. Typically occurs in the condition associated with diminished mesenteric fat. And how are you going to diminish that? Normally, mesenteric fat is here, and it's contributing to the effect of cushioning. But if you have a diminished mesenteric fat, for example, if you had a rapid weight loss, you went on a ketogenic diet. I'm just kidding here. But anything that causes a rapid weight loss, you're not eating anything or something, starving the food, who knows what. But rapid weight loss, low body weight, malnutrition, gastric bypass surgery, all of them are the risk or associated feature causing the SMA syndrome, in which you are going to obstruct that duodenum. When you obstruct that duodenum of the third part, you are going to get intermittent intestinal obstruction symptoms, primary postprandial, okay? Postprandial pain. As soon as you eat the food, that food is obstructed. Guess what? You're going to have pain now. Okay, yeah, that's what do we have here? And one more thing here, you can also mention about severe burns. Severe burns is also associated with severe burns. Also like lordosis, surgery for scoliosis, the back problems and all that. But this is just to keep in mind. But that's all for the SMA syndrome. Let's talk about again the GI, blood supply, innervation. So you have this, the celiac, the SMA, IMA, again foregut, midgut, hindgut. They supply the structures, that you already know that you're supplying this. Again, look at this thing. This is new. Pharynx, vagus nerve only, from lower esophagus to the proximal duodenum, the liver, the gallbladder, the pancreas, the spleen. We already talked about that, but this is the new thing. The SMA is going to supply from, again, we have talked about this thing, from distal duodenum to proximal two-third transverse colon. IMA, distal 1/3 of the transverse colon to upper portion of the anal canal, right? And here the parasympathetic for foregut is vagus, midgut vagus, hindgut is pelvic splanchnic nerves. SPLA splanchnic nerves from S2 to S4. Okay. That's pretty much what we have here. So it says sympathetic innervation because we talked about parasympathetic here only. Sympathetic innervation arises from abdominal paravertebral ganglia, the celiac, the superior mesenteric, and the inferior mesenteric. Okay, sympathetic comes from the paravertebral ganglia. Great. Let's talk about celiac trunk now. Celiac trunk. Celiac was the thing that we talked about first. It is the anterior branch. And then you have the celiac, the SMA, and IMA, right? So celiac here, the first thing, it branches the celiac trunk are the common hepatic, the splenic, the left gastric, these constitute the main blood supply of the foregut. So although the celiac, as we know, the celiac is a trunk, it has the branches which supply the foregut. And anastomosis, strong anastomosis exists between left and right gastroepiploics and left and right gastrics. So let's look at that. That is important. Here in the picture, we have a celiac trunk. The celiac trunk is giving off first branch, which is the left gastric, and the left gastric is going down. If you look here, it's going down. It is anastomosing with the right gastrics, and the right gastric is coming from another branch, like distal branch of the common hepatic. So that's the first anastomosis. See, left and right gastrics. So left gastric, right gastric. Okay. The second thing is the second branch of this thing again is the common hepatic. Right here, celiac is giving off common hepatic. Common hepatic is coming and it's giving its proper hepatic, which is going to give you a branch of this right gastric, but also it has all these branches of the gastroduodenal posterior. The important branch is that it is giving you a branch which is called right gastroepiploic. That right gastroepiploic is going and anastomosing with the celiac splenic splenic branch that is giving you the left gastroepiploic. So again, left gastroepiploic coming with the right gastroepiploic, making anastomosis. Left gastroepiploic is the branch of the splenic, while the right is branch of the hepatic, common hepatic, and also see this one left gastric, which is the actual main branch, is going to go with the right gastric, which is the branch of, again, common hepatic, which is all written here. Now, one thing which is important, important point here is look at these short gastrics. Short gastric. See, they don't have any anastomosis, right? So if you were to have anything occluding the gastric artery, the splenic branch, then there will be no anastomosing. So if you mess up the short gastrics, let's say you mess up here, or here, you have no blood going to the short gastrics, your greater curvature of the stomach will have no blood supply. So when you have no blood supply to that is going to cause ischemic injury. Okay? Because this greater curvature does not have a dual blood supply. Okay? So if you were to block splenic artery, you're potentially risking the greater curvature ischemic injury. Okay, that's one how you tie in. Other than that, yeah, pretty much that. And we will be talking about more things later. So yeah, what do we have here for the portosystemic anastomosis? Portosystemic anastomosis. It is basically, you have to think about site of anastomosis. What is the site? The site is, first thing is esophagus. So let's look at the esophagus site here, as it is mentioned, point 1. So this purple color is a portal venous system. The blue color is the systemic venous system. So we are doing an anastomosis between the portal and the systemic. That's called portosystemic anastomosis. So here's the first anastomosis. Here, the first thing we are looking at is you have this left gastric anastomosing with esophageal veins. And this anastomosis is called it occurs at the level of esophagus. But if you have a pathologic blood in portal hypertension, the flow, instead of going into the normal way, going over there, what's going to happen is you have varices formation because of the portal hypertension. But let's read. So as I mentioned, the left gastric, as here, left gastric was going to the esophageal vein and draining, and that esophageal vein will drain into the azygous vein. Okay. So that's the first portal systemic anastomosis. The second anastomosis is at the level of umbilicus. What is that? You have the paraumbilical vein that are going into the inferior and superior epigastric veins. So inferior plus superior epigastric veins. So again, paraumbilical, small epigastric veins, a bunch of the inferior and superior epigastric vessels of the anterior abdominal wall. The third thing is rectum. In the rectum, you have the superior rectal going into, where is the superior rectal? Is right here. It is going into the middle and inferior rectal veins. So if you have varices now, so you have the varices of gut, butt, and caput medusae are commonly seen with the portal hypertension. So you will have varices seen in these areas if you have portal hypertension. How do you treat it? The treatment is TIPS between the portal vein and hepatic vein. Let's look at that. So you have the portal vein. Important vein was the influx into the liver, and hepatic vein was the outflux from the liver out toward the IVC. So when you connect the influx to outflux directly, so you're bypassing the liver, so that is called TIPS. So again, let's read that. It is between the portal vein and hepatic vein. It resolves the portal hypertension by shunting the blood to the systemic circulation, bypassing the liver. TIPS can precipitate. Now the problem is, you're bypassing liver. Liver is not a small organ. It is doing a lot of work. So when you do bypass it, there's a risk that it can precipitate hepatic encephalopathy due to decreased clearance of ammonia from shunting. So increased ammonia causing encephalopathy. That's the risk factor to that shunting. TIPS. Okay, other than that, what else we can give as a treatment? We can do TIPS, as we mentioned. We can also do portal caval shunt. What is that? We remove spleen. Well, that's something more like CK stuff, but something that you can keep in your mind. We can give somatostatin like octreotide. Octreotide, very important. They haven't mentioned. They should have. Octreotide. What that is going to do? That's going to inhibit the release of glucagon and VIP. Remember, octreotide is like a blanket. It's going to inhibit every single thing. Somatostatin. So, but here, in the context of portal hypertension, we're looking at glucagon and VIP. So what is VIP going to do when you inhibit all of them? It leads to, normally these were causing vasodilation, splanchnic vasodilation. So when you inhibit these, guess what? You're not causing any vasodilation, but you're causing splanchnic vasoconstriction, So when you're doing vasoconstriction, you're decreasing the portal blood flow. When you decrease the portal blood flow, that is going to decrease the portal pressure. And that's what we want. We want to decrease the portal pressure. The third thing you can use a beta blocker. The fourth thing, that is with this ascites, that can lead to spontaneous bacterial peritonitis. So give an antibiotic, but these are all extra. Just remember octreotide. Okay, moving on to the pectinate line. Okay, also called the dentate line, formed where the endoderm, the hindgut, meets the ectoderm. Okay, this is the pectinate line, also called the dentate. It is formed where the endoderm, so this is all endoderm, meets the ectoderm. Okay. So let's talk about above the pectinate line. We have the internal, above pectinate line, you have internal hemorrhoids. And there is a risk of causing adenocarcinoma. What are internal hemorrhoids? Let's talk about them. They are the abnormal distension of the anal venous plexus. Look at the picture A. Risk factors include older age people with chronic constipation, receive visceral innervation, and are therefore not painful. So they're not painful, and they are in older age chronic constipated people. As compare this thing with the below pectinate line, we have external hemorrhoids, anal fissures, squamous cell carcinoma. External hemorrhoids, they receive somatic innervation, inferior rectal branch of the pudendal nerve, and therefore painful, external painful, if thrombosed. Okay, and then you have the anal fissure. You have a tear in the enoderm below the pectinate line. Now the question might ask you, where's the tear? It's a longitudinal tear. Longitudinal tear. Midline. Second thing wording is the midline tear. Longitudinal. This is the anal canal. Longitudinal tear. This is also called midline tear. Pain while pooping, blood on the toilet paper. Look at it in the posterior midline, because this area is poorly perfused. Most common location, posteriorly. Why? Because this is poorly perfused. That's why when you give the treatment, you want to relax. You want to give some relaxant or vasodilators to kind of get the blood here, which is going to heal that fissure. But again, it's a painful thing. Pain while pooping. Toilet paper, you have this blood. What else? Associated with, if you have a low fiber diet, which is going to cause constipation, that's the risk factor to that. Here they haven't mentioned one more thing, that is the imperforated anus. What is imperforated anus? That is basically you have a child who cannot pass meconium during the first days of life. So when you take a look at it, you see a dimple. Instead of an anal canal, you have a dimple instead of the anal opening. What are the associations? I mean, if you have an imperforated anus, you will have some other abnormalities too, right? So you have a urinary tract defects, for example, renal agenesis, bladder extrophy. Again, remember your vectoral Ventral. A for anal defects. This is the anal defect, so you can have all of them. You can have anything as far as the ventral goes, right? So that's the imperforated anus. What else? Yeah, so let's talk about now the picture, the main guy in on the page. That is this picture. Okay, pectinate line. Above the pectinate line, we have the nerve, and below the pectinate line, we have all of them. It's the same things, but names are different. So let's see. So you have the visceral, because it's a viscera, so visceral innervation, inferior hypogastric plexus, inferior mesenteric artery, inferior mesenteric vein. See, the whole thing is one structure if you look at it. Inferior mesenteric. Something inferior, right? So here, you have the inferior hypogastric plexus, inferior hypogastric. You can't have a vein for the nerve, right? So that's why it's not a vein. You have inferior hypogastric plexus. That's from T2 to L3, but T12 to L3, but that's why. Just remember inferior hypogastric plexus. Arteries are a branch of IMA, inferior mesenteric artery. What is that branch? Superior rectal artery. Superior rectal artery. Again, superior rectal artery, superior rectal vein. So all you have to think about, inferior hypogastric plexus and superior rectal artery, branch of IMA, superior rectal vein, branch of IMV. Great. And lymphatics, they drain to the internal iliac lymph node. Internal, because it's a viscera, internal iliac lymph node. Okay. Let's read the now the below the pectinate line. So what do we have? In below the pectinate line, we have a somatic innervation from pudental nerve. Up top, we had the superior. Again, at the bottom, see, we're talking about below, right? So inferior, right? So this is like superior, this is inferior. So again, so everything with inferior. Inferior rectal artery, inferior rectal vein. So inferior rectal artery is the branch of internal pudental artery. Pudental nerve, pudental artery. Inferior rectal vein is also a branch of the internal pudental vein. That is going to go drain into internal iliac vein, go into the common iliac vein with IVC. Now, this is important. It goes into the superficial. Why would it go to superficial? Because it is superficial skin, right? It is like skin. Skin is going to go into the superficial inguinal lymph nodes, while this is more like a deep structure. It's going to go to internal iliac lymph nodes. Although you can say, okay, internal iliac is here, internal iliac. But no, that's lymphatics internally is going to the internal iliac. And for superficial, it's just superficial, so it's going to superficial. Okay, all you have to remember is just this. In the superior, you have the inferior hypogastric, and you have the superior rectal artery, and superior rectal vein. And lymphatics is going to the internal organs or internal iliac, something like that. At the bottom, you're looking at pudental, and also looking at inferior rectal artery and inferior rectal vein, right? And that is draining into superficial, because it is superficial. Yeah, that's what we have here. Let's see what else we got. Okay, liver structure. In the liver structure, we have the functional unit of the liver is made up of the hexagonal arranged lobules surrounded by central vein. Look at the picture here. So we have a central vein. This is the central vein. This is a hexagon. So The functional unit of the liver is made of hexagonally arranged lobules surrounding the central vein and with the portal triads on the edges. So you have the central vein in the center with the portal triads on all the hexagonal edges. Okay, that's the portal triads. Consisting of portal vein, hepatic artery, and bile ducts. So one is the vein, artery, and the bile duct, as well as lymphatics. Now the apical surface of the hepatocyte faces bile caniculi. Look at the apical surface. They're saying apical surface. Apical surface of the hepatocyte faces bile caniculi. Bile caniculi are here. And this is draining into the bile ductule. So this is the apical surface. Basolateral surface of the face, they face the sinusoids. If this is apical, let's say, then the basolateral surface face the sinusoids. So sinusoids are here, okay, and this is the sinusoid. So this is going to be our basolateral surface. Not that important, just writing it out, but not important. What is important is the hexagon, the zones, and what's messing up the zones. So let's just read. Kupffer cells, specialized macrophages located in the sinusoids. So these Kupffer cells, which are the macrophages, they are in the sinusoids. Important. So sinusoids have these macrophages called Kupffer cells. They are located in the sinusoid, clear bacterial damaged and or senescent RBCs. Hepatic stellate, very important. E2 cells in the space of Dicey. Space of Dicey has the stellate cells, which are also called E2 cells. These store, one thing is they store vitamin A when they're quiescent, when they're inactive. And they produce extracellular matrix when activated. So they produce the extracellular matrix when activated, and they are the ones which are responsible for hepatic fibrosis. So when they're active, they are the people, not the people, but they are the cell which are responsible for fibrosis of the liver. Let's look at the blood supply. Dual blood supply of the liver. The portal vein contains about 80%, and hepatic artery contains about 20%. Now the zones, you have the periportal zone. Looking at the picture here, periportal means you see this is the portal triad. So periportal, one thing is the periportal. The second thing is the intermediate, because it's between these two zones, and the third thing is the pericentral. This is the central vein. So pericentral, because it's closer to the central vein. Periportal, because it's closer to the portal triads. And in the mid one is the intermediate. Okay, so let's read which one affects what. So in the zone 1, it is the viral hepatitis. So as the virus enters, it affects the zone 1 as soon as it enters the liver. It is the area which is best oxygenated. Yeah, the blood is coming right. That's the first point where the interaction of blood occurs. So definitely it's oxygenated. It is most resistant to circulatory compromise. Why? Because you already said it's highly oxygenated. It is the first part. So ingested toxins like cocaine are the ones which are going to mess up this area first. So what is it? So you have the virals, the viral things, the viral hepatitis, and also the cocaine. They're messing the first area, zone 1. Zone 2 is yellow fever, with the zone 2 for yellow fever. Zone 3 for pericentral centrilobular zone, affected first by ischemia, because it is the least oxygen. Let me erase this and show you. It is the least oxygen. Look at this thing. This area is the least oxygenated. This is most oxygenated. So because you have a least oxygenated, you can cause ischemia to this area, but you have really important cytochrome P450 enzymes system that is based here. It is most sensitive to metabolic toxins like ethanol, CCl4s, rifampin, and acetaminophen. So metabolic toxins, which are metabolized by P450, are going to mess up your zone 3 because zone 3 contains the P450 enzymes. So guess what? All the metabolites that are going to get metabolized and become an active ingredient, which is going to cause toxicity, that is the zone 3. That's why you have the zone 3 being active, being messed up in the metabolic toxins, like ethanol and all of them. It is the site of alcoholic hepatitis. Again, same thing. Alcoholic hepatitis, again, zone 3, while the viral hepatitis, zone 1. So alcohol, digestion, and all that, it's a metabolic toxin and all that. Okay. Something that is important, that even if you have the arterial occlusion infarction, the liver is going to be one of the last organs that is going to go into ischemia because of its dual blood supply. So based on that thing, so the question is, what is the most susceptible organ that can go into infarction from highest to lowest risk? From highest to lowest, so you're looking at CNS is the first organ to go to say bye-bye, right? After that, you have the myocardium. Myocardium is like, okay, I can't take it anymore, bye-bye. After that, you have the kidneys, which are going to say, hey, you can't pee anymore, bye-bye. Spleen is like, if everybody else is dead, I can't eat RBCs, man, bye-bye. Liver is like, man, I am the last guy standing, but since you're all dead, I'm saying bye-bye too. But most important here is the CNS, which is the highest risk to go into, which is susceptible to infarction, right? And the lowest risk, the liver gets the lowest risk. Okay. What do we have here? Biliary structures. Biliary structures, we have the cholangiography shows, look at the cholangiography, filling defects in the gallbladder, okay, shows in the arrow A, okay, and common bile, which is the red arrow in A. So you have the filling defects. This thing is the cholangiography. It's showing the filling defects in the gallbladder and also the common bile. Let's read. Gallstones that reach the confluence of the common bile and the biliary ducts at the ampulla water can block both the common bile and the biliary ducts. So basically what they're saying is, gallstone, you have a gallstone that is going, coming, and let's say lodging here at the confluence where the common bile duct and the pancreatic duct, they are being joined together at the ampulla water. If you have a gallstone that reaches at this point, what's going to happen? You're going to block not only the common bile duct, this thing, so you're blocking this thing as well as you're blocking the main pancreatic duct, because you have blocked the confluence of them, the where they joined, you blocked it, so by the gallstones. So that's called the double duct sign, causing both cholangitis and also pancreatitis. So gallbladder cholangitis, pancreas pancreatitis. That's only if you have here, if you're blocking at the confluence of them. So let's read the other things. But if you have a tumor that arises here, you have a tumor of the pancreas that arises at the head of the pancreas, usually ductal adenocarcinoma, cause obstruction of the common bile duct, right? That leads to enlarged gallbladder with painless jaundice. That is called Courvoisier's sign. Okay, so if you have a tumor, again, if you have a tumor at the head of the pancreas, obstructs the common bile duct, which is, if you have obstruction of the common bile duct, enlargement of the gallbladder, that is gonna enlargement of gallbladder plus painless jaundice, because the gallbladder is not, secretion is not going down, it's gonna go back, cause the liver, it's gonna flow back. You will see jaundice. Okay, that is called the Courvoisier sign. Let's read something if there is any important. There are plenty important things here. What else here? So you can think about it as if you, now let's just erase this. If you have a gallstone, which is here at the fundus of the gallbladder, or you have the fundus of the gallbladder, you have the body of the gallbladder, you have the neck of gallbladder, and you have the cystic duct. If you have a stone in the cystic duct, a gallbladder stone that lodged into the cystic duct, it's going to cause a biliary colic. Biliary colic. And what is that biliary colic? Basically, intense spasmodic pain in the gallbladder without jaundice. Okay, that's the first thing. But if you were to have if you were to have just a stone in the gallbladder fundus, or within the fundus of the gallbladder, what are you going to have? So that stone, which is in the fundus of the gallbladder, may go into the duodenum. So it may go into the duodenum and ulcerate into the transverse colon, bypassing everything and going into the rectum and going out, saying bye-bye to you. So again, if you have the fundus, if you have the stone in the fundus of the gallbladder, the fundus of the gallbladder, that may ulcerate the transverse colon. So wait, I talked about duodenum, that's something else. But here, that is going to go into the transverse colon. If you have a fundus, if you have a stone in the fundus of the gallbladder, that's going to go into the transverse colon. After the transverse colon, it's just going to go straight out of the rectum and saying bye-bye to you, right? But again, now I'm going to talk about something else. If you have a stone which is lodged into the body of the gallbladder, that can ulcerate and go into the duodenum, and that will be blocked by the junction, ileocecal junction, right? Because that's the tightest thing here, ileocecal junction. That is going to cause, so as soon as you block that, so you have blocked it here. So now what's going to happen is you have intestinal obstruction symptoms. And when you do the x-ray, you will have the gas in the gallbladder and gas in the biliary tree. Gas in the gallbladder and the gas in the biliary tree, but you have an obstruction because of that stone passage. Okay? And now I already talked about that cystic duct here. So this thing is done, this thing is done. Now let's talk about if you were to block the common bile duct here. Remember, the common bile duct is not only draining the gallbladder, but also the liver, right? So if you were to block the common bile duct, what's going to happen? That is going to give you cholangitis with jaundice. Same thing as of the tumor said with the Courvoisier sign, right? And if you were to just this thing is almost the same thing as the head of the tumor, pancreas. Okay. So what else? So you have So again, rephrasing everything. If you block the fundus that is no problem. It's just going to go to transverse colon, going to the rectum, say bye-bye to you. But if you have a body gallstone in the body of the gallbladder, that's going to go into the duodenum, will be blocked by the ileocecal junction, will cause intestinal obstruction, signs and symptoms. Cystic, if that gallbladder stone gets out and gets into the cystic duct, and the cystic duct, you, as soon as you block just the cystic duct, you have a biliary colic. What is that biliary colic? That is the intense spasmodic pain in the gallbladder without jaundice. There is going to be no jaundice. And one more thing about this biliary colic is, if you eat fatty food, that's going to stimulate your CCK, and that is going to stimulate your, let me write here, that's going to stimulate CCK. CCK is going to stimulate your gallbladder motility. Again, you will have pain. So as soon as you eat fats, you're going to have pain. Okay, that's pretty much what we have for this thing. All right. So that's all for today, guys. See you some other day now.